Hello, everybody. This is Dr. Kurt Wohler here for another webinar through Great Plains Lab. I appreciate you joining me tonight. This particular webinar, some of it's new, some of it will be a recap if you've listened to past webinars of mine. This is really meant for health care practitioners, but that certainly could involve parents as well. So the information is, easily crosses over to multiple people. I will get into a little bit more specifics on, specific treatment dosing of antibiotics and those types of things tonight. So the real emphasis here is to kind of hone in on, kids, teenagers, adults on the autism spectrum who are having gut problems, and what I feel is really important for doctors, and that could be other healthcare practitioners. That just doesn't mean just MDs or DOs, but anybody in the health field, things that they should be aware of with respects to what's happening with these kids, and kind of highlight some of the more common things. So like anything in biomedicine, we could spend hours upon hours upon hours going over different clinical scenarios. So I'm really going to focus in on behavioral issues with respects to autism linked to the gut. So a lecture overview is just discuss briefly autism and the comorbid conditions, which is actually becoming more well recognized in traditional medicine. Then talk about common GI problems, various behaviors related to constipation. I'll go through a few case studies here and case examples of different behavioral problems associated with GI issues. I've done these slides before, but show some examples of inflammatory bowel documented in certain individuals on the spectrum, and then get more specifically into how intestinal pathogens can negatively influence behavior. We're going to get more in-depth into Clostridia and some of the biochemistry behind Clostridia-induced issues. I've done this talk, or at least part of this talk, for various physician groups, over the years. And really what I try to emphasize is that the problem we have in biomedicine, and I think as parents, the struggle that you may have when you're trying to work with a doctor to get them to understand what you're talking about with respects to your child, behavioral problems linked to digestive problems and other issues, is trying to break through the prejudice, if you will, that the medical community has about autism, in that what I believe is that many practitioners are prejudiced by the diagnosis. So once the child has a diagnosis of autism, it's almost as if their clinical insight into any physical problems is thrown out the window. And so this slide I've used over and over as an example of, if you took the same physical or presentation, clinical presentation of a child. Here's the child on the left whose physical milestones are delayed, chronic diarrhea, recurrent sinus, ear, upper respiratory infections, eczema, bloating, gas problems, and to get rid of that. And maybe they've got some anxiety and attention issues. Maybe there's some irritability and they're not sleeping real well. But that child does not have a diagnosis of autism. Generally what's going to happen is the doctor will do some testing. They might do some blood testing, see if there's an immune problem, see if there's deficiencies of anything. They might do a stool test to say, hey, do we got a problem with an infection? They're going to do some kind of diagnostic workup. Now, as I've seen, as the years have gone on, I have seen the medical community get a little bit better at starting to run some tests for kids on the spectrum, but it's not great. But if you take that same scenario with a child with autism, at least in the past, and it's still going on now, many parents are ignored and the kids are sort of just forgotten, just sort of chalk it all up to their autism. Well, when you look at the DSM-4 and now the DSM-5 criteria for autism, nowhere on that criteria list is chronic diarrhea or eczema or abdominal bloating or recurrent sinus, ear, and upper respiratory infections. It's not on there. So the problem we have is a medical community that's often prejudiced by the autism diagnosis. So what are some of the list of comorbid conditions? And these things are well recognized. This is actually coming from the Centers for Disease Control. And they recognize that in the autism community, ear and respiratory infections are more well represented. Asthma, allergic rhinitis, atopic dermatitis, sleep disorders, headaches, migraines are more prevalent. Seizure disorders and gastrointestinal disorders, which we'll get into tonight. So in this abstract right here, which was out of the European Journal of Pediatrics in 2012, says it, specifically, comorbidity is to be expected in the autism spectrum disorders either directly or indirectly, and those comorbid conditions may be markers for some underlying pathophysiology. So as a healthcare practitioner, you have to do testing. You've got to look at these kids as having underlying medical problems to try to deal with those medical problems to help improve their overall condition. So what are some of the common GI problems in autism? Well, just like everybody else, individuals on the spectrum suffer with stomach inflammation, gastritis, gastroesophageal reflux disease, colitis has been documented, irritable constipation, motility-based disorders, that's basically peristaltic activity issues in the gut, oftentimes leading to constipation, food allergies and sensitivities, and then quite commonly are the overgrowth syndromes of bacteria and yeast. And there's a lot of research out there. This is just an abstract from 2006 in a Journal of Developmental Pediatrics talking about the increased prevalence of intestinal problems with kids on the spectrum. And what they did is they looked at 50 children in each group, and they found that 28% of children with typical development had some kind of GI problem: nausea, bloating, gas, constipation, loose stools. But when they compared that to kids on the spectrum with autism, that shot up to almost 70%. So a huge, huge shift with kids on the spectrum having GI issues compared to kids of similar age who are considered neurotypical. And then that was backed up in 2013 in a journal article looking at gastrointestinal problems in children with autism. And essentially they found very similar results, that frequent GI issues affect young children with autism and developmental disorders much more commonly than typically developing child. So that brings us back to the whole discussion about comorbid issues. And then this is Dr. Bowie, a statement by Dr. Bowie, who does work with kids on the spectrum doing gastrointestinal evaluations, and really kind of driving home the point. This was actually in 2010 in the Journal of Pediatrics, talking about GI issues. They need to be recognized, and that they need to be medically treated, and that many times behaviors can be directly linked to what is happening in the gut, and that just drugging kids with psychotropic medications is largely ineffective and honestly bad medicine. You got to get at the root of the problem. If you want to understand more about comorbid problems that have been well documented in autism, I would highly recommend getting this pamphlet. You can go to autismtreatmenttrust.org. This is a group or groups, my thing's not shifting here, out of the UK, and this is they've done a brilliant job as far as putting information in a cohesive way, very understandable, well-referenced, good abstracts about the various comorbid issues. So if you have a doctor who's hesitant to help you as a parent, or you as a physician are working in a practice where maybe some of your colleagues are kind of poo-pooing what you do, this is a great thing to give them. Okay, so let's talk about some of the more common things. And this is 3 different scenarios involving constipation, because constipation is a big problem as a comorbid issue in autism. Case 1 was a 5-year-old individual. Age of autism diagnosis was at the age of 2.5. Main issues, very typical of many kids: expressive language problems, social withdrawal and avoidance, sound sensitivity, non-aggressive or self-injurious, which was good news. Physical examination had kind of that pregnant belly look. And a lot of repetitive behaviors. And an odd behavior was the child would lay flat on the floor and rub back and forth, just back and forth by laying flat on the floor with the abdomen on the floor. And so the parents reported that, he had normal bowel movements every day, but a lot of foul-smelling gas. And so an x-ray was obtained, and if you look, it's kind of hard to tell, but there is a lot of gas and a lot of stool built up in the child's colon. And so they didn't, the radiologists who read the report, they didn't show any evidence of intestinal obstruction, but there was a tremendous amount of colonic gas and what's called fecal residue obscuring the abdomen and pelvic area. And so essentially what was happening with this boy is that it was the only way for him to relieve the pressure, the uncomfortableness of having a belly full of poop, was that he would lay down and rub back and forth on the floor with his to try to get some pressure relief of the uncomfortableness that he was feeling. Uh-oh. Okay, that one happened there. Hold on one sec. Let me go back. Okay. So case 2 is, this was a, hold on one second, let me get myself oriented. Okay, so case 2 is a 12-year-old individual. Age of autism diagnosis was at the age of 3. Now he's considered to have more Asperger's. Some language, issues, but overall, conversational. Socially awkward, kind of tends to lack personal space boundaries. Behaviors, a lot of anxiety, particularly at school, and has also had a lot of anxiety in association with using the bathroom. And the main concerning behavior becomes obsessive and combative emotionally when he complains of his stomach hurting. So the child had reported that his stomach often hurt after eating and often throughout the day. The parents noticed that the child would bend forward on the toilet when trying to have a bowel movement and could spend sometimes upwards of 30 to 45 minutes trying to go to the bathroom. Pediatrician, did some things, checked for H. pylori to see if there was an infection in the stomach, tried some reflux medication, none of it really helpful. And so things like magnesium oxide were implemented, seemed to help a little bit, and then over time parents would do things like Dulcolax suppositories when he was younger. Got some relief, but nothing was real consistent. Eventually was referred to a gastrointestinal specialist who did an examination and found out he had rectal prolapse. And so, essentially the amount of straining that this child had been doing for so many years was causing the rectal area to lose its tonicity, and he was starting to prolapse the rectum. And so through dietary changes, some magnesium citrate with Miralax, increased fiber, and some probiotics, things started to improve over time, and the bathroom issues started to improve as well. And then case 3 of another more, kind of an interesting example with respect to constipation. 14-year-old boy, 2.5 years the age of autism. Diagnosis considered severe, nonverbal, poor socialization, a lot of anxiety, a lot of sensory-seeking behavior. The main physical challenge was that he could be severely constipated, literally not having a bowel movement for 5 to 6 days at a time. And various remedies were tried. Dulcolax suppositories and Miralax, and physical examination showed that hard, pregnant belly look that we get with a lot of kids. The main reason for the consult, though, was this incredible aggressive behavior and these destructive tantrums that he would go into. So to kind of get the process rolling here, a main intervention for constipation was employed using a Fleet's enema and doing that prior to 2 hours of Miralax dosing. And this was kind of a shotgun approach. This was, hey, we got to get some poop out of this kid to see if that might help them feel better. So after doing a Fleet's enema, Miralax half cup in 6 ounces of water every half hour for 6 dosages was used. And then that was followed by a Dulcolax suppository 1 hour later. And this was done for about 2 days in a row, and then slowly transitioned over to a half cup twice daily of Miralax for 3 weeks. And then we started to also incorporate some ground flaxseed. Slippery elm is an interesting herbal remedy. You can find it at most health food stores. It's not really dosed based on age or weight. It just helps to make the poop, fecal matter, more slippery. In this case, we use 6 capsules a day. You could use 2, 4, 6, 8. There's not a specific amount. And then magnesium citrate, 400 milligrams daily for long-term maintenance. Well, this was just one stool sample that this particular boy released. And this is a police flashlight, which is quite large as comparison. Massive amount of dumping over a 2-day period of time. He just had so much old stool being built up in his GI system. What happened was the mother reported that within 4 days of bowel evacuation, his aggressive tantrums diminished by about 75%. Overall, he was happy, more calm, less agitated, sleeping better. So, the mother was quite pleased. The problem was he still remained aggressive at times, and particularly when he was being reprimanded for negative behavior. So not anything really associated with constipation. There was still some aggression left, but it was greatly reduced. So I inquired a little bit further about his aggressive behavior. And this is an important lesson, is that not everything in biomedicine, not everything that we do has a biomedical link. And what I found out was that this particular boy named Stephen would only hit his mom, he would hit his sister, his aunt, and in the past, his grandmother. But he didn't hit any males in his life. Didn't hit brother, didn't hit his father, or his grandfather. So I asked, well, what happened with grandma? Because you mentioned that grandma had been hit in the past, but that was past tense. Well, it turned out that grandma got tired of being hit. And one day, grandma got frustrated, and no one advocates, aggressive or violent behavior, but grandma slapped the child back in the face and stated, "Don't ever hit me again," because she was tired of being abused. Well, it turned out that he never hit his grandmother again. And what I had learned in that lesson, what I tried to relay to the mom, was this was not a biomedical problem. This was not a supplement fix. You couldn't give a medication for this. This was a behavior that had been learned over time and unfortunately allowed to happen in the house for much too long a period of time. I know there's some philosophy in behavioral therapy with younger kids to kind of look past this type of behavior, but anyway, in this particular situation, it was quite severe and had gone on way too long, and so this particular boy had a real problem in that he would only hit women in his life. So anyway, that's a kind of a lesson learned. It certainly was for me at that time. All right, so what about aggression and self-injurious behavior? In this particular case, often associated with eating. So it's not always a constipation thing. This was a 7-year-old boy. He's a twin, born C-section. Age of diagnosis, 2 years. Autism issues, typical lack of expressive language, poor social interaction, self-stimulatory behavior. Prior to his medical, the medical issues per se, there was, well, I guess just say prior to his autism diagnosis, he had some episodes of projectile vomiting that occurred around the age of 1, and that was suspected to be linked to reflux. He was generally a very picky eater, very fussy, and so there were some feeding issues that were going on. What was interesting was that some significant behavioral changes occurred around the spring of 2013, where he started doing some self-injurious behavior, headbanging, biting the back of his hands, and particularly became aggressive around mealtime. So this all shortly occurred after the family was moving from Texas to Kentucky and started to have a lot of allergy symptoms, itchy eyes, runny nose, sneezing, and was placed on some allergy medication. Got some relief with the medication, but the aggressive behavior associated with the meals continued. Had a pretty sharp doc, pediatrician, who referred to a pediatric gastroenterologist who performed endoscopy. And what they found was that this particular boy had eosinophilic esophagitis. And the eosinophilic esophagitis is an inflammatory condition in the esophagus where the eosinophils, part of the immune system, starts to infiltrate itself into the mucosal lining of the esophagus. And this is just a biopsy report from this particular child where they're talking about intraepithelial eosinophilia, documenting this particular condition. So what they did is they put the child on an acid blocker and a restricted diet to try to turn off the immune system or turn things down. Okay, and this is just another part of that report showing that sections of the esophagus show intraepithelial eosinophilic infiltrate. Well, after some intervention, after the acid blocker, restricted diet, etc., another biopsy was obtained, and the eosinophilic inflammatory component in the esophagus and throughout the bowel showed normal. So there was great improvement there, but just as important, there was nice improvement with behavior. Essentially, within about 2 weeks of the initial therapy, his self-injurious and aggressive behavior diminished by about 75 to 80%. Within 1 month, there really were no more issues. And this was at, particularly with this particular boy, for the first time, had typical eating behaviors. Well, so there's some examples of, some issues with constipation and, in that particular case, eosinophilic esophagitis. But in some kids, it gets even more severe. And that's where we start running into the problems of inflammatory bowel problems that often go undiagnosed because no one bothers to look. And I've done these slides before, but the majority of these are from Dr. Arthur Krigsman, who's a pediatric gastroenterologist in Texas. He's done a lot of work with kids on the spectrum. And there's a couple presentations that you can watch here. When this presentation is recorded, this will be recorded and posted on Great Plains' site. You can go back and look at this. But if you just go to callous-disregard.com, you can do a search for Dr. Krigsman's presentation and get a little bit more insight from what I'm presenting here. So essentially, these are all intestinal images, endoscopy, colonoscopy, etc. So we have normal tissue on the left, and we've got this eosinophil infiltration of the esophagus. By the way, that previous case, this is essentially what's going on, is the eosinophils infiltrate into the esophagus, causing eosinophilic esophagitis. Okay. Well, the inflammation can also occur in the stomach, leading to duodenal ulcers and inflammatory polyps. In some severe cases, we've got situations where kids are refluxing, not only refluxing acid up into the esophagus causing pain, but actually refluxing bile. In this particular example was a child refluxing bile up into the esophagus. And what's been correlated with this is a lot of, behavioral problems, pounding on the chest, holding stomach, associated with tantrums, aggression, all of those things that may lead us to believe that there's certainly some pain going on. In other particular circumstances, this was an image of a child refluxing not only bile, but stool, fecal matter, up into the stomach. Severe intestinal motility issues, big problem. And so this kind of goes to the heart of doing the physical examination and looking at the distension of the abdomen, how bloated some of these kids can be. The small intestine is a place where a lot of inflammation seems to take place in autism. It's a very highly immune active area, particularly the terminal ileum, one of the most highly saturated places with all of the immune cells. And so again, if we've got a lot of inflammation in that area, we can have a child who's not digesting food properly, cyclical loose stools and, constipation, behavioral problems associated with it, all sorts of issues. Again, the problem is most kids aren't being examined. And then one of the ways that inflammation in the lower bowel, the ileum area particularly, is looked at is through a pill cam. And this is a pill cam is it's a pill, a camera in a pill, that's dropped off in the upper part of the intestine. The child wears a monitoring belt. And then as this thing moves through the GI tract, it's taking pictures and transmitting those pictures to the recording device in the belt. And this is a very effective way of looking at inflammation down in the ileum. So, and that's exactly what we see here, is severe inflammation of the ileum, the last part of the small intestine. Well, we can also get inflammatory lesions in the large bowel too, which is what gets picked up through colonoscopy. So inflammatory bowel disease is clearly a documentable medical problem in some cases of autism. Well, one of the other things that needs to be looked at and appreciated is the stool consistency. So opposite end of the spectrum with constipation is kids who have chronic foul stools. This is not normal. Every once in a while you may have some loose stools, but if this is a chronic ongoing problem, despite all your best efforts of treating yeast or bacteria or specific carbohydrate diet, the likelihood of some kind of severe inflammatory problem is going on. Okay, so as Dr. Krigsman puts, if most or all of the stools are unformed, it's pathologic, and that needs to be taken seriously. The other thing, as medical practitioners need to recognize, is that oftentimes young children will posture themselves across furniture, the edge of a table, the arm of a chair or couch, pressing their abdomen to the floor. This is not a normal behavior. This is not playtime. They're often doing this to try to relieve pressure. Small children don't have the upper arm strength to try to, get a relief pressure, for themselves, so they find some other object to try to do that. So I always ask parents, are your kids posturing over furniture like this? And that is a clear indication of something going on in the gut. Now, it could be purely they're constipated, kind of like the case before, where the child was rubbing back and forth on the floor. But sometimes it's more problematic. And then self-injurious behavior. Not all self-injurious behavior is going to be linked to gut problems. They know that self-injurious behavior can be linked to seizure disorders. They know that certain neuroanatomical problems in the brain can be associated with self-injurious behavior. But in my experience, the vast majority of self-injurious behavior in autism is linked to some underlying comorbid problem. Constipation, bacterial problems, food sensitivities, some kind of pain response. Not always, but quite commonly, 80% or more often. All right, so let's shift our focus now to gastrointestinal pathogens and how these things can negatively influence brain function. There has been a lot of interest, if you will, in traditional science, traditional medicine about the role of the gut, the microflora of the gut, and the effect that that can have on mood and behavior and overall health of the brain. This is getting much more play now in traditional medicine, and will continue to do so, and that's a good thing. This is an interesting article that came out in the journal Cell in 2013. And what this particular research was looking at is they took these mice that had autistic features, and they measured in the blood a chemical or a profile of chemicals, and they found this one called 4-ethyl phenyl sulfate. And what they did is they gave these mice what's called a commensal bacteria, Bacteroides fragilis. And what happened is it has been known to help correct gut permeability. It helps to improve the microbial composition, if you will, in the GI tract. And what they found in these mice is that it helped to eliminate the communicative, the stereotypical, and the anxiety-like behaviors that these mice had. And when they actually took neurotypical mice and they injected that particular metabolite, these particular mice developed the autistic characteristics that you were used to seeing. And so taking that together, what they found is sort of suggesting that the gut, the microflora of the gut and the brain are connected, and that a potentially, something like probiotics could be useful to help kind of turn things around. So we're going to come back and talk about this particular paper a little bit more. This is an article that Dr. Shaw wrote back in 2010. His primary research on the HPHPA chemical, the 3,3-hydroxyphenyl-3-hydroxypropanoic acid, which is a byproduct of Clostridia bacteria in the gut. In this particular paper, he was looking at urine samples in patients with autism and schizophrenia. Clostridia is a problematic bacteria. It's an anaerobic bacteria. It means it doesn't like oxygen. It exists in colonies just like many bacteria do. But it can be a real problem because of the toxins that it produces. One particular toxin is, as Dr. Shaw highlighted, called HPHPA. Well, it turns out that HPHPA has been known about for a long time. This is a journal article going back to 1957, Journal of Biological Chemistry, that was looking at this particular chemical that was found much higher in mentally ill patients, first, patients with mental retardation, as they stated, and their levels of HPHPA were much higher than in, essentially normal people. This is their verbiage, or neurotypical people. A lot of the play with respects to bacteria, Clostridia causing problems in autism got at least some emphasis and some publicity based on this particular study back in 2000 in the Journal of Childhood Neurology, where they were using vancomycin on a group of regressive autistic kids. These were 11 kids who had regressed on the autism spectrum after they were given some type of a broad-spectrum antibiotic. And that was followed by chronic persistent diarrhea, a deterioration in skills that they had previously acquired, and that the overall worsening of their autistic features. And they got, 8 of the 10 kids got improvement for a short period of time when they took a short course of vancomycin. But the problem is the benefits didn't last. So what they came away with this article was they weren't really suggesting a protocol, but they were sort of indicating that, again, the gut flora plays a connection to the brain and that further research needs to be done. Well, let's just focus in a little bit on the biochemistry, the chemical structure of this HPHPA, the 3,3-hydroxyphenyl 3-hydroxypropanoic acid. We notice that it has this 6-carbon ring, this benzene ring, that has a hydroxyl group attached to it. And then we've got this propanoic acid grouping on the outside on carbon 1. This particular structure, this 6-carbon ring with the hydroxyl group, is called a phenol. Okay, so they're calling it a phenyl group or a phenol. We'll come back to that in a sec. If you go back and look at Dr. Shaw's information from Great Plains, this particular article that was in 1995, where they were looking at 2 brothers with autism, comparing it to neurotypical individuals of their urine samples, they found that the autistic brothers had really high levels of all different kinds of these chemicals. And in this particular one, they were primarily focusing on arabinose specific to yeast. However, there's this other peak, this HPHPA, that kept showing up too. When they did further evidence and further research, this particular slide is very similar, if you see my presentations before on yeast, is that in groupings of autistic individuals, they generally have higher levels of candida toxin, arabinose, compared to control kids of either the same age or younger. Now, a lot of people have arabinose. It just is that the autistic kids tend to have much higher levels of arabinose associated with yeast. Well, this particular paper was also discussing that same type of pattern exists with HPHPA. And if we look here, they're looking at 211 kids between the age of 2 and 13 with very high levels of HPA compared to control kids, where there is some elevation, but just not as prevalent. I think also what's happening with kids on the spectrum is that they are more neurologically sensitive to these toxins than maybe other people are. If we look at the biochemistry of what happens here, and this is important from a clinical standpoint for docs to understand, is the relationship of dopamine and norepinephrine. Phenylalanine is an amino acid that we get through our diet. And phenylalanine is converted to tyrosine. Tyrosine is converted to dopa, which is converted to dopamine. And we know the role of and problems in dopamine metabolism in Parkinson's disease. Well, it turns out that if you've got Clostridia bacteria, okay, Clostridium difficile or other types of Clostridia bacteria, they can take that tyrosine and convert it into a couple different toxic compounds. One, HPHPA, the other, 4-creosol. Both will inhibit the enzyme that converts dopamine to norepinephrine. And it's called dopamine beta hydroxylase. So Clostridia, as a general rule, have the ability to produce toxins that inhibit the conversion of dopamine to norepinephrine. And why is that a problem? Well, if you look at the overlap of the primary neurochemicals in the brain, dopamine, serotonin, and norepinephrine, dopamine is important for attention. It's also important for mood and overall cognitive function. It helps in the regulation and the stimulation of appetite, sexual desire, and in too much can lead to aggressive behavior. Norepinephrine, it has a function over attention and focusing as well. It also is involved in mood and overall cognitive function. It's involved in alertness and concentration. But you start to create problems in norepinephrine. It can lead to anxiety, impulse issues, and irritability. And then, of course, serotonin has a crossover aspect with all of this as well. So it's the interrelationship of these neurochemicals that keeps a balanced brain neurochemically. And we start to create an imbalance in either one of these systems, we're going to have a problem overall. And what commonly happens with individuals on the spectrum is that when their dopamine levels go up in association with Clostridia, they often become aggressive, self-injurious, and sometimes a lot of erratic behavior. Now, this is just one particular case looking at HPHPA associated with Clostridia in relationship to the dopamine chemical called HPA. So what happens is dopamine eventually is broken down into HPA, and that's what's being measured in the organic acids test from Great Plains. So as the Clostridia levels go up, so did the HPA levels. As Clostridia levels went down, so did the HPA levels. And in this particular case, they were tracking it with norepinephrine because the HPA, i.e. dopamine, is not being converted over to the norepinephrine side adequately. Now, as I mentioned, it's not just HPHPA. It could also be 4-creosol. 4-creosol is very specific to Clostridia difficile. Now, this has not been completely proven, but it is a suspicion, is that some of these other markers on the organic acid test, the hydroxyphenylacetic acid, the hydroxybenzoic, the hydroxyhyperic, that it's felt because of their chemical similarity to all of these other chemicals that they might too inhibit that dopamine beta hydroxylase. Not 100% confirmed, but it's a possibility. There's some recent research that's come out that shows that number 11, 4-hydroxyphenylacetic, or acetic acid, is actually a good marker for small intestinal bacterial overgrowth. So that marker alone shows why the organic acid test is a must-do test for any doctor, healthcare practitioner working with patients doing integrative medicine, and for any parent to need to do with respect to their child. Here is the article that was really talking about the aspect of Clostridia difficile and the 4-creosol. So why is Clostridia difficile producing creosol? It turns out, as they're stating here in red, Clostridia difficile is one of a few bacteria that can take the tyrosine and convert it into this toxic compound. I want you to pay attention to this. It is a phenolic compound, a phenol, that is toxic to other microbes via its ability to interfere with their metabolism. So the Clostridia difficile is producing 4-creosol as a defense mechanism to one-up, if you will, other bacteria in the gut. Now, it turns out there are some other Clostridia that have been able to combat that, but isn't it interesting that these bacteria are producing these compounds to try to outdo their neighbor, so to speak. But in the process, it has these negative effects on our biochemistry. And it's a phenol. Why is that important? Well, it turns out, based on some research in the Journal of Biochemistry, look how far some of this stuff goes back. 1983. I love when I hear doctors, traditional doctors, say there's no research to support any of this. There is tons of research, stuff that goes back years and years and years. It's just that most docs in the traditional medical community haven't bothered to look, and so it's just convenient to say there's no evidence or no research exists. It's ludicrous. Here's another thing I want you to focus on. We know that p-creosol or 4-creosol is a phenol, okay? And what they're saying here is that p-creosol is a major metabolite of Clostridia. It is a strong inhibitor of dopamine beta hydroxylase, which converts dopamine to norepinephrine. But a wide range of phenols can do that. Okay, what that means is it's not just a phenol from a bacteria. It can be phenols from foods, phenols from other chemicals, phenols that may be involved or coming in through an artificial ingredient of some sort, or even a natural ingredient in a particular food, may have that same type of effect at blocking dopamine and norepinephrine, inhibiting that dopamine beta hydroxylase. Okay? The other thing is this reaction is irreversible, specifically with respect to p-creosol. Once that p-creosol attaches to the active site of the enzyme, it essentially destroys the enzyme, and it's not reversible. Okay, so that's why it's important to treat the Clostridia when you see it. Now, one thing here, and this is one of those things that, let me go back, and I don't have it written here, but I want people to understand this. Normally we need copper and we need an adequate supply of vitamin C to help activate the dopamine beta hydroxylase enzyme to work. Okay, so if you have a vitamin C deficiency, a copper deficiency, then you may have underactivity of the dopamine beta hydroxylase. It is quite possible, which I don't know of any tests at this point, but there may be mutations. Certain people may have mutations within the dopamine beta hydroxylase enzymes that increases their potential to having problems, just like we see mutations in the MTHFR enzymes. So it's possible that that could be happening here as well. Well, it turns out that in the presence of Clostridia toxins, in the presence of P. creosol specifically, that vitamin C actually increases the binding of P. creosol to that enzyme. The only problem in me making this kind of statement is, I don't know what that is. Is it 1,000 milligrams, 500 milligrams, 2,000 milligrams of vitamin C? You know, it's from my understanding at this point, it's not well defined. Okay, but there's that potential. So what I've done clinically in my practice anymore is when I have a person where I see the P. creosol high, and I'll also do it honestly if I see the HPHPA high, and we have a negative influence where the HVA level is high and the ratio between HVA and VMA is high. Usually that ratio between HVA and VMA, you know, ideally approximately should be around 1.5 or so. When you start getting up around 1.82 and above, then you're likely having some inhibition. I will tend to hold off on any additional vitamin C supplementation. Now, person may be getting some vitamin C through their food, and that's one thing. But I'll hold off for a little bit before I start giving them 500 or 1,000 milligrams of vitamin C. And that's just, for me, a precautionary approach. And you know, hopefully some of you who start working more with this can help all of us learn, you know, what if there's a better way of doing things with respect to some of the vitamin C supplementation when these things are present. Okay, so now let's come back to this particular journal article in the journal Cell. All right, so these were mice that had autistic characteristics. They found this 4-ethylphenol sulfate. They gave them Bacteroides fragilis to try to, you know, improve the microflora, if you will, the environment of the gut. And when they did so, there was an improvement in the autistic characteristics in these mice. Well, as I mentioned, this particular compound was actually found in 46 times higher the amount in the autistic mice than the non-autistic mice. And when they injected this compound, 4-EPS or 4-ethylphenol sulfate, into mice that didn't have autism, they took on autistic behaviors. So what do you think this 4-ethylphenol sulfate is? Well, it is a phenol. It is very chemically similar to P. creosol from Clostridia. So they didn't discuss this in this article, but likely what was happening is that it too was inhibiting the dopamine beta hydroxylase. There are other compounds, as I mentioned. Here is our phenol group, our 6-carbon ring with our hydroxyl group. And we had a glycine, okay, and we developed a structure called 2-hydroxyhyperic acid. This is a metabolite that is often found in aspartame. It's found in aspirin, found in various foods, and additives. This is a phenol and could create problems with that converting enzyme. Acetaminophen, okay, another phenol group with an amino compound here off carbon 1, another phenol. And here is our structure of P. creosol from Clostridia, also called methylphenol. We've got a benzene with a hydroxyl group and a methyl group at position 1. All of these things are phenols. So what happens when we have excess dopamine? Why is that such a problem? This is a very complicated slide, a lot of stuff going on here. But the gist of it is this. When we get an excess production of dopamine, that dopamine can spill over to create toxic compounds. One of those compounds, called cyclidized dopamine oquinone, can end up essentially sucking up glutathione reserves as the body tries to deal with the oxidative stress. We can also create these other compounds that have a direct killing effect on the nervous system. The bottom line with excess dopamine is that 90% of the dopamine is actually stored in the storage vesicles in the axons or the nerve cells. But about 10% of it is floating freely, essentially what's called in the cytosol or the cytoplasma. And that's the form that tends to be highly reactive. So it drives a lot of oxidative stress, and in doing so, it can deplete glutathione and create all kinds of problems in the brain. Well, if we focus again on Clostridia, as I mentioned before, it's a strict anaerobe, so it dies when it's exposed to oxygen. There's all different kinds of Clostridia. Tetanus is a Clostridia bacteria. Botulism is a Clostridia bacteria. The other problem with Clostridia is it forms spores. And these spores are very difficult to eradicate. And they now know that there could be upwards of 100 species or so of Clostridia in the digestive tract. Not all of them are pathogenic, okay, but there's a lot of these guys. Generally, they can be controlled by antibiotics, certain probiotics, but sometimes they're very difficult to get rid of. And there have been many recurrences after treatment, whether it's with herbal remedies, whether it's with antibiotics, whatever it may be. Bleach is one of those things that has been known to help kill the spores of Clostridia. And that is probably why, in some cases, the chlorine dioxide that is quite popular today is showing some benefit for, some of these cases, in that it's likely killing off some of the spores of Clostridia. So it turns out that carriers who are not symptomatic may also spread the spores. One of the reasons that I advocate, if we've got a situation with Clostridia in a child, that family members get tested too. So it's worth doing an organic acid test on other people in the home. As you would expect, if we use something that killed the Clostridia, you would also expect that the HPHPA levels to drop. And this is what this particular article was showing. Start a metronidazole, which is called Flagyl, HPHPA levels come down, and then they start to come up again, okay? And this was one of the problems we had early on when we were only using a certain day's amount of metronidazole, and I'll talk about that here shortly. One of the other things about excess dopamine that's important from a clinical standpoint is that dopamine infiltrates itself into the autonomic nervous system, particularly in the areas where the nervous system utilizes norepinephrine, okay? And that is often why when you have excess dopamine, you will see an individual in that fight or flight response. The sympathetic, this right-hand side of the chart here, becomes oversaturated and activated. Dilated pupils. Saliva sometimes is inhibited. Sometimes an erratic or elevated heart rate. Inhibits peristaltic activity, can lead to constipation, poor digestion, and on and on and on is sort of the whole fight or flight response aspect. Why I'm bringing this up is because if you come back and you take a look, what is the main nerve center or the nerve pathway that connects our digestive system to our brain and nervous system? Well, the primary agent here takes place through the vagus nerve. I mean, anatomy is very complex, and that may be a bit simplistic, but the vagus nerve plays a big role. Let's talk about that. This was an article back in September 2011 that was talking about how the ingestion of lactobacillus as a probiotic can affect emotional behavior by essentially activating what's called GABA. GABA receptors in the brain. GABA in the brain can have a calming effect, but it was doing it via the vagus nerve. Now, how would that happen? Okay, so we've learned that Clostridia can produce these toxins, and other bacteria too. We know that yeast can produce toxins in the gut, but how are they getting into the brain? Well, for the most part, they get filtered. So they get absorbed into the lymphatic system, dumped into the circulatory system, and these things are then taken throughout the body, okay, through the circulatory system. Well, it turns out that it may be a more direct way that these toxins can have an influence on the brain. There was a very interesting article that came out in 2013 by an individual from Harvard Medical School, as well as an individual in the Department of Physiological Sciences out of Warsaw, Poland. And what they're talking about is the microbiome, the environment of the gut, and the connection between the brain and its relationship to autism. What they found, and what they discussed in this article, is that stress. Okay, and this is something we've talked a lot about in the integrative medicine community for many years, is that stress, physical stress, emotional stress, mental stress, a combination of all that, okay, has a negative impact on an individual on multiple levels because of the connection between the brain and the adrenals connection to every organ system in the body. And what they found is that animal studies that show that animals that are stressed, that stress even changed the composition of the microbiome of the gut, increasing vulnerability to inflammation in the gut. And that another mechanism of problems is that stress is known to inhibit gut contractions, so that the colonization of the gut becomes much more prevalent as bacterial and opportunistic bacteria are not flushed out in our stool. Now, this is one of the theories for small intestinal bacterial overgrowth, is that you get exposed to something, some kind of toxin irritates the lining of the gut, alters peristaltic activity, and you start to develop these colonies of bacteria in the gut that create all kinds of problems and maybe find their way into areas where they shouldn't be, even normal flora. The other thing what they found is that when that early psychological trauma, when they separated these animals from being able to bond with the mothers, that also increased problems as far as behaviors and the microbiome of the gut. So what does that have to do with the vagus nerve? Well, the vagus nerve is a direct conduit. It's a direct neuroanatomical, playing a neurophysiological role between the gut and the brain. And what this research was showing, at least suggesting, is that there's a direct communication between the bacteria and the brain from this vagus nerve connection. It turns out that the vagus nerve is involved in modulating the immune response. So it is involved as well in helping to control inflammation. And that when they cut the vagus nerve in these animals who were having anxiety behaviors and depressive behaviors, those behaviors improved. They didn't do anything else other than just cut the vagus nerve, and there was an improvement in the animal's outcome. Well, to take it one step deeper, and we track it back to the discussion about Clostridia, they found that, we know that oral antibiotics can disrupt the microbiome in the gut, and they basically then shift the environment for more opportunistic bacteria. One particular type of Clostridium called Clostridium tetani, which produces the potent neurotoxin, tetanus neurotoxin, it's been known that that particular toxin can be transported from the gut through the vagus up into the central nervous system. And what do you think are the target areas in the brain for the tetanus, at least one of the areas? Well, it turns out that the tetanus neurotoxin targets the Purkinje cells of the cerebellum, which are often abnormal, by the way, in kids with autism, and they tend to blow out and create a problem in the GABA neurons. So we start to create an imbalance in the GABA system of the brain because of the Clostridium tetani. Now, I don't have any proof that other Clostridia are doing this, but if we've got a situation that's been documented that Clostridium tetani, the tetanus neurotoxin, can be taken directly from the vagus nerve. By the way, the vagus nerve's function, 80% of it is what's called afferent, which means it's taking information from the peripheral system and bringing it back into the central nervous system. If we've got tetanus neurotoxin doing it, is it possible, is it plausible that other toxins from Clostridia could be doing the same thing? Certainly a place to look for research. I think it certainly is possible. So now we've got two things that are going on. We've got neurochemicals that are being produced, that are being absorbed systemically and circulated throughout the circulatory system, affecting the brain and nervous system. And then we've got direct communication up through the vagus nerve neuroanatomically by what's going on in the gut. Well, now it comes down to treatment, okay, and just some treatment options for practitioners out there to consider, with respects to Clostridia. And this is not a real in-depth talk on all of the treatment options that would require an entire other seminar, and we will do that in the future. But I'm going to go through a few things. Because remember I mentioned to you that there's a high recurrence rate with respects to Clostridia. The problem has been that I don't think we've been treating it correctly in years past, and we get a rebound effect. There was an interesting article that Dr. Shaw presented about a year and a half ago in the Journal of Medical Microbiology. And this was specifically talking about Clostridia difficile, where they looked at recurrence rates based on the way things were dosed. The typical standard dose, as you'll see here, at 10 days, okay, using about 1,000 milligrams a day. And then they did a higher dose. Oh, we'll just bump it up, do 10 days at 2,000 milligrams, and showed some effectiveness. Then they started to do a tapering dose, which, by the way, I learned about a number of years ago from online gastroenterologist. They did a 6-week taper of vancomycin for Clostridia difficile, where you give a higher dose more frequently, and then as you drop it down, you start to decrease your dosing. And that showed some benefit. But really where they got the long-lasting benefit is by pulsing it, okay? Not dosing it every day, but doing pulse doses, where they're using it on alternate days, in this particular case, every 3 days. Well, why do you think that would be? Well, it turns out that the spores of Clostridia they're not affected by antibiotics, okay? So you're not going to kill off the spores. So the theory is this: if you've got spores, and let's say you've got colonies of bacteria, but you've got the spore forms, if you constantly are bombarding those colonies with an antibiotic, those spores are never hatching. They're never shifting their state into a form that is then antibiotic responsive. So essentially the spores are staying in the spore form. And then when you back off in your antibiotics, the spores change form and the colony essentially emerges again. So what we found is that if you hit the colony for a period of time, in this particular case I'll usually do vancomycin or Flagyl for about 10 days, and then rotate the treatment. So you essentially do a treatment day every 3rd day for about 3 weeks. This seems to have, and has been having, a much greater effect at reducing the Clostridia. There's another protocol where you can just do an every other day dose of vancomycin or Flagyl for 4 to 6 weeks. I've not personally done that. I've tended to do the 1 dose 3 times a day of either vancomycin or Flagyl for 10 days, and then do every 3rd day, do a treatment day. So that would be 1 dose 3 times a day on that day, every 3rd day for 3 weeks. And then I'll do a repeat, either a repeat organic acid test or a microbial organic acid test from Great Plains during that last week. I want to see if we're getting a good reduction of either the HPHPA and or 4-creosol while on the therapy. Now, people often ask, well, are there any natural options? And this has been a struggle, to really kind of come up with something that's been consistent. But I feel like I personally have, whether I stumbled upon it, just sort of took the principles of what I've learned over the years, I've seen some pretty good results with a remedy called biocidin. Let's talk about that. This is just an example here of some organic acid test. And this particular one was dated, this was back in January 2013, where we saw the HPHPA high, 396, and this was just, I won't go into in-depth about the individual here, but this was a kid that has some struggles. So we decided to do a vancomycin at 10 days and do a 30-day of diflucan just to kind of deal with the yeast, okay? And so what happened is it worked, okay? It knocked it down a bit, and we went a little bit too long in retesting. I mean, I like to get retests sooner, than later, but sometimes that doesn't happen. So anyway, the HPHP level came down, and on secondary testing, we saw a level of 152. The child was doing a little bit better, but was still kind of having some behavioral issues. And I thought, all right, the parents didn't want to redo another course of antibiotics, plus vancomycin can be expensive. So I said, let's try some biocidin along with Culturelle, and let's do it for a couple months and see what kind of effect we get. So we did that, and unfortunately what happened was that, it wasn't as effective and, from what I was hoping to see. Matter of fact, over time, the HPHPA level came back really high, okay? So we're not getting that effect that we wanted to see. So I said, okay, let's shift gears. And right around this time was when we started to learn about this research of doing the cyclical dosing. Instead of just doing every day, start to look at doing cyclical dosing based on the antibiotics. So I then took that principle and said, all right, if we do 10 days of Vanco or Flagyl, and then every third day do a treatment day for 3 weeks, how would we do that with natural remedies? So I said, all right, my typical approach when you're using herbal remedies is generally to use them for a longer period of time, whether that's for bacteria, yeast, or even parasites. So I said, all right, let's take the biocidin, and instead of doing it for 10 days, let's just do it for 14 days. And then instead of doing a cyclical dosing afterwards for 3 weeks, let's do for 4 weeks. Let's just extend it a little bit, okay? And I went ahead and also added in a little bit of grapefruit seed extract, and we did some Culturelle, which I typically do anyway. So I used, a pretty good dose of biocidin, 2 capsules 3 times a day for 14 days. Then every third day, we did another treatment day, kind of using the biocidin like we used the Flagyl and vancomycin. And I mentioned to the parents, look, I said, if this doesn't work, we're going to need to implement a longer antibiotic program. Well, it turned out it did work. Matter of fact, the HPHPA, if we go back, was at 426. It came down to 43. So I said, all right, kid was doing better. I said, let's just retest, okay? Let's retest again a few months later, and sure enough, it still has remained normal. Now, the HPHP is coming up a bit, but that's a big drop just on using herbs. Well, what about 4-creosol, okay? So this is example 2. In this particular case, I used the drops of biocidin. Same thing, 14 days, then every third day, do a treatment day for 4 weeks, did a little bit of grapefruit seed extract, some Culturelle, okay, and the parent was doing some Candex, so that's fine, okay. By the way, notice the level of other bacteria here, okay, these bacterial markers. But we're focusing right here on 4-creosol, which is sitting at 204, okay. After doing that, the 4-creosol normalized, and we saw a nice shift in these other markers as well. So the 4-creosol normalized. Okay, so I've got many different cases like this. Matter of fact, these slides are in part from a larger presentation that I'm doing with these one-day intensive seminars on the implementation of the organic acids test into a clinical practice. So if you are a practitioner listening to this, I highly recommend. I'll show you the cities and the dates that we're looking for right now in 2015. We've already done Seattle and Houston. If you're interested in this kind of work, want to learn more about it, I'd highly recommend you attend one of the organic acid trainings, one-day seminars that we're doing throughout the country. So as an example, biocidin, 1 to 3 capsules 3 times a day for 14 days, 5+ drops, then every 3rd day, 1 treatment day for 3 to 4 weeks. Okay, that's sort of a rough example. And then you can incorporate a few other remedies into that as well. And this is one of the slides that I've talked about with respect to biocidin. Biocidin is a nice remedy. It's a combination of different things. It's very potent. So it actually, the liquid actually lasts quite a long time. And there's some dosing recommendations that they give off their website. I kind of, sort of will dose things on my own. I don't necessarily follow a specific protocol based on their website. Usually when I'm dealing with Clostridia, I'm getting a little bit more aggressive because I know how problematic that bacteria can be. But this can be used for other bacteria. This can be used for yeast. I have seen personally in the past biocidin help with a parasite called Blastocystis hominis. It's been known to be effective against certain molds as well. So it's a useful remedy. And they also have capsules as well. The nice thing now is that biocidin is available, at least the liquid, the biocidin liquid is available through New Beginnings. So if you are a frequent user of New Beginnings Nutritionals, you can now access the biocidin liquid through their website. It's in the botanical section. Here's the slide on these organic acids tests one-day intensive for health practitioners. We're going to be in San Francisco January 24th. These are all Saturdays. Then we're going to be in San Diego on Saturday, February 21st. Chicago in Saturday, April 11th. And then in Washington, D.C. on Saturday, May 2nd. And there'll be others that'll come about afterwards. So, but these are what Great Plains has right now. So if you're a healthcare practitioner and you want to learn more about this kind of work and certainly learn more about the organic acid test, go to the website, see what city is closest to you, and learn some more information. All right, let me just kind of wrap up this evening's discussion about a typical case with respects to Clostridia. Okay, and this was a 5-year-old boy, diagnosis of autism. He was 5 years old at the first time of his visit. No pregnancy complications. Overall typical development up to approximately 10 months. The parents did report he seemed to lack a lot of need for physical contact, but nothing stood out much from there. They breastfed for a year, then they began cow dairy and solids around 6 months. At about 11 months, they started to know that his eye contact started to disappear, but he was still happy and playful, was engaging with his sibling. Physical milestones were fine, etc. Language-wise, he never got any real word development, but there was some babbling, at least early on. About 15 months, they saw their pediatrician, said, hey, we're kind of concerned about this, but pediatrician said, let's just kind of watch and wait and see what happens. Medical history, multiple ear infections for the first 2 years. Parents reported child always seemed like he was on some kind of antibiotic for ear problems. Gut issues tend to be more constipated than anything. Periodically, they'd have to use some suppositories. About 18 months, he developed an intestinal infection, got a fever. About 3 days, used some Tylenol to kind of help him feel better. And then they didn't give any antibiotics because essentially the pediatrician felt it was due to a virus. About 2 weeks after the onset of the fever and the diarrhea, the child became much more agitated and very irritable, and just his appetite wasn't normal. And then about 20 months, things really seemed to just disappear. So there was no expressive language, poor social interaction. At this point, he wasn't even interacting with the sibling, the neighborhood kids, whatever. Became easily agitated, started doing a lot of self-stimulatory behavior, side glancing next to the TV screen, finger twisting, became fixated on that kind of behavior. So they saw the pediatrician. The pediatrician referred to a neurologist. The neurologist did some expensive testing, all came back normal. So the parents, like many parents, started looking things online, doing some biomedical research, said, we've got to try the diet. So they implemented a casein-free diet and immediately saw some improvement. With a gluten-free diet, thereafter, not much change. Not much change. Did some probiotics, seemed to help a little bit more. And then they wanted to do a multivitamin. They gave a multivitamin that had very high dose B6, and the kid got really hyper and agitated. So they pulled that from his regimen. But overall, for the next year, things seemed to kind of stabilize regarding, his condition and his overall physical health. And then about age 4, the child developed an upper respiratory infection and was given an antibiotic. And within a very short period of time, about a week, he became incredibly agitated, aggressive, scratching, biting, screaming, just couldn't be consoled. And this behavior kind of shifted on and off for a number of weeks, tended to lessen a little bit, never fully went away. Parents started doing some research, tried some grapefruit seed extract, tried some other herbal remedies like caprylic acid, saw some improvement, some lessening behavior, but not completely. So I come on the scene. My suspicion is some kind of bacterial issue that's contributing to the behavioral issues, and so we decided to run an organic acid test. This is an older case, so I actually don't have the case anymore, but I had the presentation notes that I did long ago. This was a child that actually had an HPHPA level greater than 700. This was done at the time that Great Plains didn't have the marker for 4-creosol. All they had was the HPHPA. The HDA level was quite high for a kid, and that really indicates too much dopamine inhibiting dopamine beta hydroxylase. So I decided to implement a treatment protocol. Now notice that I did Flagyl for 10 days. If I had to go back, or if I saw this kid today, I would do 10 days, and then every third day do a treatment day for 3 weeks minimally. I also threw in some nystatin because of problems with antibiotics and yeast, and I did some Culturel. So usually 3 to 4 capsules in most cases works fine. Why I'm showing this case is that the turnaround was unbelievable. Within 5 days into Flagyl treatment, the aggression and irritability disappeared completely. Within 3 weeks, he was back to the happy, content, and playful little boy. The parents continued the diet. They started to just see overall improvement from that. I eventually came back and requested repeating an organic acid test, but they never came back. Okay, so essentially the patient was lost to follow-up. So I never knew exactly what happened. I hope things turned out okay, but it was the reason I show this case was the turnaround in this kid was really fast when we started hitting the Clostridia. It is also a thing for the parents who are listening to make sure doing some repeat testing, okay, to make sure that we've got confirmation that we're getting rid of these bacteria. So with that, I hope everybody got some benefit out of this. If you are a parent and if you are a doctor and you want to have more interaction with me, you can do so in a number of ways. You can, I've got a website called Autism Action Plan. It's a subscription website. It's $37 a month. There's no long-term contracts. You can join it, cancel it, whatever. But it's a place where parents go, no matter where they are in the country, and I've got people from all over the world who access me through the website. Post me questions, ask me a question, send me a link, what are my suggestions, troubleshoot issues, whatever it may be. There's actually a section for private messaging too. There's also videos and protocols on the website as well. And a lot of doctors will join that and post me privately for just, helping to kind of brainstorm things. So that's Autism Action Plan. And then if you want to get more direct information about my consulting practice, you can do so through the contact information here. Our patient scheduling line is 951-461-4800, and then our email is info@mysunrisecenter.com. And I do consulting for people all over. So with that, everybody, I hope this information was useful for you. We will do some more talks on this topic in the future. We'll actually take it to another level here with respects to other types of treatment protocols. If you happen to type in a question, Great Plains will catalog that, and they will email those to me later. I don't have the ability to go through and answer everything now, but I answer those in written form at a later time. Usually I get those within a few days or a week or so after one of the webinars. This particular webinar, like all of them, are recorded, so this will be up on Great Plains' website too. With the holidays, I'm not sure how long it'll take, but anyway. So I hope everyone has a wonderful holidays, and again, we will see you next month for another installment of a webinar hosted by Great Plains Lab. Take care. Thanks so much.